Well, I think the idea of the talk was to really see what the guidelines, state today in terms of how do you evaluate a vascular patient in your office before you do anything at all in terms of medical management or intervention, treatment, and so forth. And then obviously once you've done something, whether it's risk factor modification, or in this case, whether you've revascularized a patient, how do you follow them and do surveillance afterward? And so that's kind of what the talk was really focused on, is I tried to frame it rather than focusing on my algorithm. I try to talk about what do the guidelines say, whether you look at the Society of Vascular Surgery, SIR, ACC guidelines that just came out, what are the standards out there today? And so that's what I tried to focus on. I mean, I think what we really tried to showcase is that when somebody comes into your office with a vascular problem, the data is quite good. A good history, good physical exam, especially a vascular exam, focusing on non-invasive testing, whether that's an ABI, duplex arterial ultrasound, and then there's other higher end imaging studies like tissue oxygen, perfusion, and CTA and MRA. And so I really kind of talked about what makes the most sense today based on what the data shows in terms of evaluating these patients prior to treating them, and even afterward, how do you follow them at that point? Well, I mean, data show that there's a lot of evidence right now that really ABI is a good, after the history and physical and a good vascular exam, an ABI is a good test to really kind of confirm the diagnosis of peripheral arterial disease, and that, if you're going to revascularize somebody or treat them, then the next step would really be some higher end imaging such as pulse volume recordings, segmental pressures, ABIs, which we talked about, and then obviously duplex arterial ultrasound is really the first line kind of evaluation. Well, I think the main thing to realize is that when you really look at the data, and OEIS really published a lot of this data of 45,000 patients, is that really the quality of the vascular care and how people are treating patients, whether it's in a outpatient center, in this case it could be an OBL, it could be an ASC, or a hospital, is that it's quite similar in a lot of ways. I mean, there's some nuances, but overall the endpoints and the treatment algorithms that people are using are very similar. So I think, and also remember that most OBLs and ASCs are regulated by the Department of Health of whatever state you're in, and sometimes by national accrediting bodies as well. I think the main thing, a lot of trainees and early career physicians are always asking me about, how do you evaluate somebody? And I always say, look, there's a lot of algorithms out there on how you should evaluate these patients, so you don't have to guess. Somebody comes to your office, you do a good history and physical, you do some basic non-invasive testing to really clinch the diagnosis of PAD, and then you figure out, do I really need to treat them? Yes, then you go down a different, kind of part of the algorithm. If you don't need to treat them with something invasive, then you go down the pathway of medical management and exercise, wound care, depending on what they have going on.